So I'm going to stick my not particularly foot and ankle trained nose into the foot and ankle afternoon as well. Talking about some of the challenges of treating infection in the foot and ankle. And it's really just because of how hard I've found it in my first 5 years as a consultant. So as I mentioned earlier, I trained in Oxford at the bone infection unit there. And so whenever I go back to do talks like this, I tend to sort of reflect on my practice there and some of the publications that came out at the time I was working there. And I started going back, looking through some of the big series that were published from our unit at the times I was working there. So that was when I was a sort of CT looking at tobramycin. And a big case series, 195 cases. Of these, I think there was 3 foot and ankle cases, no diabetic foot in that case series at all. Then there was this one when I was back there as a fellow that came out just before I was a fellow, actually. So this is when we'd started using Xeramint G. And this was their first 100 cases. And again, there were 3 foot and ankle cases, no diabetic feet. And similarly, a long-term review that was published a few years after that, again, didn't have any diabetic foot. And it suddenly made me realize that actually when I was working there, we didn't do much diabetic foot work in the bone infection unit. And partly that was because there was a separate group of foot and ankle surgeons that were doing it. But it started to make me reflect on, this is supposedly the biggest infection unit in the country. Is foot and ankle infection not really that much of an issue? By the numbers, it really, really should be. So if you just think about ankle fractures, so ankle fractures, in the UK we get about 180 per 100,000 each year is the incidence. Deep infection rates are quoted between 1% and 7%. So that generates many hundreds of theoretical deep ankle infections every year in the UK that you guys should be seeing. That pales massively in comparison to foot and ankle infections in the diabetic population, as James mentioned earlier. So, we've got over 5 million people in the UK now with diabetes, some of them as yet undiagnosed. And they've got a huge lifetime risk of foot ulcer, and about 20% of those that develop these ulcers will go on at some point to develop osteomyelitis. So now this is a pool of literally tens of thousands of patients that you guys should be seeing in your practice in future years. So it's actually an enormous infection problem that really isn't talked about very much, I think. This was 2017. The NHS was spending over 900 million on diabetic foot, and yeah, as James said, there's 100 amputations a day. So clearly we're still not doing a very good job nationally of it. And I think part of the reason it's not talked about a lot, and it's not in a lot of the big published series, is that it's really quite hard. You don't get great results compared to other areas of the body, which is why I was particularly pleased that Solario is about a quarter diabetic and about a quarter foot and ankle, actually, because it's probably more reflective of the practice that's going on in the country. Will did a really nice talk earlier about some of the principles of osteomyelitis. This is my sort of slide of my principles when I'm doing any osteomyelitis case. So you have to make a diagnosis. Is it definitely infected? You have to optimize the patient to give yourself the best chance intraoperatively. And then my stages of surgery are, I want to excise the infected tissues, I'm sampling from microbiology, I'm managing the dead space that I leave behind, I'm stabilizing the bone, and I'm getting good soft tissue coverage. And operating in a diabetic foot causes specific extra problems in every single one of these categories that you just don't see in the tibia, in the femur, elsewhere in the body. Part of the problem is the diagnostic side of things. So Volker's talk was very nice earlier. He talked about there's a very nice international guideline, consensus criteria for the diagnosis of fracture-related infection, which establishes major criteria, minor criteria. If you have the major criteria, it is an FRI by definition, sort of thing. There's not really the same in the diabetic foot. So this is the closest I've found, which is an international consensus from a few years ago. But it isn't really able to come up with any really hard criteria. They do mention the probe-to-bone test, so as mentioned earlier, which is reasonably sensitive and reasonably specific. If you can poke a probe into your ulcer and touch something hard and crunchy and bone-like, it probably is involved, and it probably is infected. They talk about failure of conservative treatment and progressive bony lysis on X-ray, but that's sort of further down the line. So it is quite difficult to make that initial diagnosis. And we do use MRI in a lot of our infection work and in the diabetic foot and ankle. We tend to do MRIs with gadolinium contrast. It does show us some useful things. So we can see communications of ulcer tract down to the bone. We can see soft tissue collections like that around the bone. We can sometimes assess the extent of osseous disease. But we were talking earlier about Charcot, and the trouble is a lot of the changes that you can see in the bones themselves in an acute Charcot foot look very similar to osteomyelitis. It's quite hard to tease the two apart. Both of them are hot red feet. Both of them you'll see marrow edema, you'll see high T2 signal. There are subtle clues that can try and help you differentiate the two of them. Obviously, if there's an ulcer, you're leaning far more towards osteomyelitis. But in the absence of an ulcer, Charcot tends to be more marrow edema subchondrally in the midfoot. On MRI of osteomyelitis, it's more commonly in the forefoot and hindfoot, near areas of pressure, near areas of current or previous ulceration. But again, it's sort of a bit of a soft differentiator. So, I agree with what James said. It is quite difficult, and you get those ones that don't have an ulcer, and it's reported as could be osteomyelitis. Well, any of these could be osteomyelitis, but how do you make that differentiation? And that probably is where those biopsies do come in, I think. If you get to the point where you've decided, yes, this is actually osteomyelitis, and you decide you want to do something, you then want your patient optimized, and particularly in the diabetic population, all of these things are things I'm not very good at as an orthopedic surgeon. So the MDT approach is really, really key here. I need the diabetologists to get the glycemic control under control. The tissues need to be perfused. If they're not, my wounds aren't going to heal. So I need the vascular surgeons to help do that. I need podiatry, I need orthotics post-operatively, or else all my clever work is going to go to naught when they get new ulcers. So without that, again, it is very challenging. And then when we get to surgery itself, I've showed this slide before, so I'm going to jump through it. So that's kind of a stepwise debridement of a tibial osteomyelitis. So you excise sequestrum, you make a bone window, you sequentially debride bone until I see a paprika sign, or Professor Shan was just happy, and it feels it's about right. Bones of the feet are really small. And any bone you can swallow is probably not worth treating. I'm sure someone told me that's not true, but they're very hard to actually preserve, I'll tell you that. So if you get a case like this, so this is one we did a little while ago. So this was an ulcer under a fifth metatarsal head, so fairly typical sort of diabetic forefoot ulcer. We did an MRI. The whole metatarsal head's involved. There's sort of a bit of a soft tissue collection wrapping its way round the lateral side of that metatarsal head. Don't know how well it projects, not brilliantly, but there's sort of edema in the bone going about halfway up the shaft of that fifth metatarsal. So where's anyone going to resect for that? I mean, if you were going to, if you wanted to debride it, Mina, what would you be chopping out? What's my necrotic bone, and what can I preserve?
The mic.
So we've got, you can see kind of up to sort of mid-shaft, there's edema there. There's sort of...
Go microscopically, wouldn't you just see what looks helping?
Well, to an extent, yeah. I mean, so there's sort of lysis and fragmentation of the metatarsal head. So that's pretty dead. That's going to go in the bin. The joint's destroyed and dislocated, and there's a hole in the base of the phalanx there. So you're going to cut something like that, and at that point you've got this little floaty bit of toe, which kind of left with an 1.5 inch gap till it meets any other bone. It's probably not any use to man or beast. So you do end up having to do more segmental resections, effectively a small partial amputation. And that's what this guy got. So In fact, you did this one. He's doing really well. This was a partial excision of the fifth ray, caught out the rest of the medullary canal, filled out with cerament, so we have local antibiotics in there. The excess skin that gave us meant we could close primarily. But you are actually sacrificing a segmental bit of bone, albeit a small one. We've talked about sampling for micro already. The way you do it is exactly the same. You still want the same number of samples. It's really good to get five micro. 1 or 2 histology is our standard. We don't tend to do very many pre-op biopsies and swabs, but I think that's probably because by the time they get to our bone infection clinic, they're really obviously infected because they've got big holes down to bone. So it's maybe less subtle than in some of the foot and ankle clinics. But the trouble with the microbiology of these diabetic patients is the population of microorganisms that you get. So I showed this slide earlier in response to something Volker said. So this was some work, two series 10 years apart from the Oxford unit, looking at the sort of spectrum of organisms they saw in all of their osteomyelitis cases. When you broke it down further, where are we? So in post-operative infections, the vast majority, I mean, it was 40-something% was MSSA, was Staph aureus that was methicillin resistant, and about half of it was gram-positive. Over a third of it was no growth at all, and there was a small population of mixed and gram-negatives. When the infection was from a contiguous focus, specifically from ulceration that then goes down to bone, all of a sudden they found that actually the simple staphs were a far smaller proportion. There was much more MRSA, and there was an awful lot more mixed growth. So that brown bar is all the mixed growth. So you tend to get far more infections with multiple organisms than you do elsewhere in the body. So just the microbiology of the diabetic foot is more challenging to deal with, I think. And then we talked about stability. There's a couple of mentions of this earlier. And you know, the options for internal versus external fixation in the face of infection. We touched on in the DARE talk, you know, if you have a good host, a sensitive organism, good soft tissue cover, then you could consider internal fixation even though it's infected. Well, the diabetic foot's none of those things, so it's very rarely an option to be putting metalwork in while it's infected, I think. The other thing we have to do with diabetic foot, which we don't do anywhere else in the body, is if there's a deformity, we kind of need to correct it at the same time, because otherwise we're not going to get, you're going to still have a deformed foot, and if you, by some miracle, get the infection to heal, as soon as the patient starts walking, they've still got the same deformity, and the same thing will happen again. It'll be just a vicious cycle of the same process going over and over again. So we tend to try and correct the deformity while we're dealing with the infection, which is sort of a double challenge, I suppose. So as an example, like this is a case that we did a few years ago. So this was on the wards under vascular. Obviously, she'd been told she needs an amputation because they all do. So she was a not very well controlled type 2 diabetic. Actually works as a midwife. She's in one of the hospitals not too far from here. And she'd had this midfoot dislocation, which had been, I think, somewhat neglected, and was referred to us when this tailor head had kind of come out through the medial skin and was sort of poking out in the breeze. She's got quite a lot of bony destruction in that area. We did an MRI, as you do, and it just shows everything looks abnormal in that area, but she's probably got a combination of Charcot and infection there, and how much of that is each is very, very hard to tell. Difficult one to sort out. We like a challenge, so we said we'd give it a go. So I started by essentially resecting that for starters. So taking out taking out a wedge of the midfoot effectively. So all this infected bone, and followed it down this sort of open track down through the midfoot. By the time we'd excised all of the medial column, we sort of needed to take out the CC joint as well, just to be able to make it foot shaped again. So that was our initial resection. And then we put a nice circular frame on. This is a butt frame, so it's one that actually goes underneath the foot, kind of loops around the forefoot. And we can use that to bring the forefoot back in relation to the midfoot and line everything up again. By doing that, it did close down the soft tissues to a great extent. We did VAC because the plastic surgeon said, well, there's no flap options for closing that medial wound. So we got it smaller and then used a VAC to deal with the rest. We talked about earlier VACs being, the tool of the devil. The reality is in diabetic foot, you don't often have an option, and actually they are better than doing nothing, and they do let you salvage things, even though technically in the osteomyelitis world they're kind of looked down upon. So she went on to have that. We eventually ended up internally fixing her because her talus largely collapsed. She healed. She does have a bit of a flat foot. We never managed to restore the arch fully with our internal fixation. But she's infection free. She's a couple of years down the line. She's doing okay. She has a foot. She's pleased with that sort of thing. It's sometimes small victories because they're never as perfect as you think they're going to turn out when you first start doing the case. And then, soft tissues. So the difficulty with the foot, there's just not much spare usually. You haven't got a lot of excess flesh, particularly around your forefoot, to move around. So as soon as you have an ulcerated area and you lose some skin, there's not much to fill that with. We're lucky we do have plastic surgeons, so they can give us some options. And ideally we'll go down the closure route. If we can close it primarily, brilliant. If there's a local flap option, that's ideal. Very rarely we do free flaps in the diabetic foot. A, their vasculature is not usually good enough, and B, as I'll show you in a minute, a free flap in a foot's not always a great thing. Because of that, we do sometimes have to resort to healing by secondary intention using either VAC dressings or antibiotic bead pouches, which we haven't really talked about too much. So essentially packing an ulcer with beads of something like an antibiotic carrier like Stimulan with an occlusive dressing over the top. And again, that delivers lots of antibiotic into the infected ulcerated area, hopefully reduces the chance of it getting reinfected through that hole that you haven't managed to close. There are a few flaps that we do use from time to time. So this is one of our plastic surgeons do quite like when it's available. So it's a medial plantar flap. So if you have an intact medial plantar arch, then they can raise a paddle of skin from your instep effectively and rotate it on that vascular pedicle to cover calcaneal wounds. So this was an oldish gentleman who had your classic calcaneal ulcer with osteomyelitis associated with it. His initial ulcerated area doesn't look too big, but by the time you actually excise the skin around it, it's certainly nowhere near a closable wound. It looks fairly horrific when the plastic surgeons first do it. So they take all this skin, rotate it 180 degrees around the vascular pedicle there, and put it onto the heel to cover your bone. And then this is an area that will take a skin graft because it's grafting down onto muscle. As I said, it looks awful at the initial follow-up, but it does actually heal in fairly well. And his disease in the calcaneum wasn't too bad, actually. It was more along the surface. So we took off the surface of the calcaneum and drilled into it to put local antibiotics in, but didn't have to do too much of a calcanectomy on him. Free flaps in the foot and ankle, problematic. So this is a chap who came from another unit, again not too far from here. He had been jumping over a fence, running away from the police for no reason at all, and he's a very good boy. He is an IV drug user and has various other things in his history. But they fixed this calcaneal tongue fracture with a couple of screws, and when he came back 6 weeks later, I don't know, that doesn't project brilliantly. So that's that calcaneal tuberosity sticking out through the skin with two screws kind of poking out towards it. So essentially all of this is exposed. Again, amputation is an option. We decided that he was salvageable, this foot. He's younger, so he did actually have decent vascular supply at least. So he had essentially excision of that infected bone, removed the 2 screws, used local antibiotics, and he's had this free ALT flap. So it's healed very nicely. You know, he's got a really good seal. The remaining calcaneum settled down all right. He's been infection-free. We did talk about him coming back for tendon transfers down the line because he no longer had any Achilles inserting onto his calcaneum, but he never wanted that. But he has been left with this. So this is an ALT flap on your heel. It's very hard to get that into a shoe. So he's sort of happy and doesn't want us to do anything more, but I wouldn't particularly want that on my foot. I've got to be honest. So the free flaps in the foot really, I think are quite limited. I think they cause as many problems potentially as they solve. And then we talked about managing dead space and the use of local antibiotics. I'm just going to skim through this quite quickly, but certainly. I think they're even more applicable here than elsewhere. I use Cerament as well a lot in the foot and ankle because it's an injectable antibiotic carrier. So you've often got quite small holes. You've got little holes down the middle of metatarsals that you can squirt the liquid Cerament in quite easily, and it sets hard. So it works quite well in my hands. It's not really an area where you can implant beads and close over the top of them, or else you just get, as we talked about earlier, lots of wound leakage and potential for breakdown. I hope the results of Solario will make a big difference to our antibiotic management of these diabetic patients, because we do see lots of them who have been on antibiotics for 6-10 weeks before they're even referred to us, and you know, you don't want these patients on antibiotics for that length of time, because they will get resistance, because they will get side effects. So if we can intervene earlier in infection and get them off systemic antibiotics, that sounds like a very good thing. The key thing once you've done all this, though, is going back to the MDT, is preventing further ulceration. Because if you just heal that infection and then send the patient back to do exactly what they were doing before, the same thing's going to happen again. So it really is key, I think, the foot care afterwards. And I think having good links with orthotics and podiatry and the diabetic foot service is important. I think it's something we're still developing. We're not good enough at, and I hope we improve with time. I think Madhu's got a considerably more evolved setup than we do, but I think that's where we need to be. So in summary, if you want to do infection, it's great. If you want to do infection and be slightly depressed about it, come and do diabetic foot and ankle infection, because it's really hard and your success rates won't be as high. But that's fine, because actually the alternative is amputation, and they're usually really grateful with you saving their foot, to be honest. And actually they are some of our most grateful patients, despite the potential bumps along the road. And that's about it, I think. That's all I wanted to say. Any questions for that?
Yes, Andy.
I was going to ask, in terms of patients who present acutely unwell with diabetic foot infection and may have like clinically a fluctuant abscess, aside from, I guess, the sepsis 6 and starting IV antibiotics, does your surgical management change? And if you have a kind of a non-foot and ankle surgeon or someone who doesn't deal with infection and something needs to be done sooner, does that change anything in terms of your surgical plan?
That is an excellent question, and it's reminded me of something I should have said and I didn't say, so thank you very much. Yes. So I suppose a lot of this is talking about the more chronic infection when you have time to plan. I think the issue with diabetic foot is they do sometimes present, acutely unwell with a hot, angry foot that's got a load of pus in it. I think if there is a collection, it needs draining, and it doesn't have to be me or one of my colleagues who does it. Someone just needs to get that pus out of the foot acutely, and then get them on appropriate systemic antibiotics to get everything to settle down before we even start thinking about this process. So it can be a sort of multi-step approach. You need to get past that acute phase so they're not really sick. The trouble is they often get referred to vascular at that point, and vascular just say, we'll chop it off. And then they get referred to us, and by the time they get to us, the foot's already not there, which is slightly challenging to reconstruct. So it's catching them early and getting that acute drainage and antibiotic management correct, I think is very important. But yeah, that doesn't have to be, that has to be the on-call in whichever hospital you are. You just have to deal with an abscess. It's like an abscess anywhere else, really, to put them on the right path.
Sorry, I totally echo that. Your problem is going to be your colleagues won't want it. So your knee surgeons, your hip surgeons, your hand surgeons, they just don't want this on their radar, so they'll just stick it straight into either your clinic in a week's time when it's too late, or they'll send it to a vascular surgeon. So I would encourage all of you to be nice people when you're older and care. And if you can, then you'll start to say, yeah, I can deal with the septic arthritis, I can deal with the bone infection acutely, I do it everywhere else in the body, I do exactly the same in the foot. Get that patient well, get the pus out of the foot, get the infection, get the septic arthritis cleared out, and then get the foot guys to take over. But it does require everyone to do it. And in most units, you've got 2 or 3 foot surgeons at most, and they're not on call all the time. And so your vascular surgeons take them on, and they do a good job. I'm not going to want to criticise them all that they do cut everything off, but they are more likely to.
Right.
Lovely.